All right, everyone, we're back with another episode of Earnest Medicine. This evening, we're speaking with an individual, someone close to me, actually, the now fiancé of probably my best friend, my college roommate, somebody I've stayed in touch with extensively over the years, even after college released us, if you want to say that. But this is somebody who I have always admired for her academic abilities. Yeah, look, she's shaking her head. No, but literally, Leanne kicked our ass in college, and we only had one course together, but it was just like, it was evident that you were going places and you are going places, and I'm just proud to know you because I think you're super smart. I think you're super motivated, and your track right now indicates that exactly. So I want to turn it over to Leanne Beasley. How's it going?
Hey.
It's going. Thanks for having me. You're far too kind and generous with your compliments there. But yeah, thanks for having me. It's an honor to be here. Thank you for having me, Dr. Brown. I appreciate it.
Of course,
absolutely.
Yeah.
So I guess just starting off a little bit about me. Like John said, we met in college. I'm not dating. I'm engaged to his best friend.
That's a good feeling. Yeah.
It is. It's very strange. I mean, we've been together for 8 years, so
Yeah.
it was time. So we're good now.
Excellent.
But undergrad at the University of Missouri, which was a comfort pick for me. Both of my parents went to Mizzou.
Okay.
So I had been at Mizzou my whole life growing up as a kid, so it felt like a pretty easy choice to go. I knew they had a medical school there.
Excellent.
And that's like the pinnacle question, right? As a pre-med, of like, when did you know you want to be a doctor?
Yeah.
I couldn't tell you.
Yeah.
Honestly, because my mom is a nurse, but she went back to school when I was in, I want to say 5th or 6th grade. So we were all grown kids by that time. And I thought nursing was pretty cool. So that was kind of like my entry into healthcare and medicine.
Sure.
But then I started to realize, like, you know what? I don't know that I really want a boss. I don't know that I want someone over me like that. Yeah. And then I thought about, maybe what about like a PA or an NP sort of thing? And like, it's still not enough autonomy. Like my dad is very type A. He raised type A women. And so I'm like, I got to have more autonomy. I got to be the one in the room.
And your fiance knows this, right? Okay. Yeah. 8 years, you better. Yeah. Okay. All right. Good.
So I don't know. It was like a natural progression to decide on medical school. Mizzou felt like a pretty good place for that to happen.
Excellent.
And undergrad, I mean, John's very generous with my academic prowess.
She was in the honors college. Kicked butt the whole time.
Well, I mean, yeah, it wasn't, to be fair, it wasn't hard to be a part of the honors college there necessarily, but
jeez. What does that say about me?
I think a lot of what these huge universities do for pre-medical students, it's a weed out scenario. I would say most of my general science classes were in auditoriums of 300 students. And to me, that doesn't really scream an importance or emphasize learning. It's more of just pushing through masses to get through. And science is not my strong suit. Science and math are not things that I enjoy, actually. In terms of knowledge, I like to learn things, but science was not at the top of my list. I was a reading, writing, history gal in high school. I was a newspaper managing editor. Like, I like to read and write sort of thing. So it was a real stretch for me to take on, pre-med. And I had, I think, a pre-med advisor suggest to me that maybe I should reconsider medicine at some point. When I think it was my sophomore or junior year, and I struggled through. I struggled through physics. I struggled through organic chemistry.
Yeah, was that a big one for you too?
No, I ate that stuff up. But but do I use it at all today? No, not at all. It was just a mental exercise. So
yeah. So she told me, because I did not pass. I think I got a D in organic chem 1, and she's like, you really should reconsider. And I'm like, well,
that is ludicrous.
I don't think so.
Exactly. That's ludicrous. But how many other people did she tell that to? And then how many of those could have been actually good compassionate physicians who where organic chemistry and benzo rings didn't matter, right? To actually caring for people. That's insane. Yeah.
Yep. So those were, it felt like an exercise in futility, right? Like just these huge classes full of concepts that felt very irrelevant. Like, I don't know how these are supposed to benefit me in any way. So I think the message I learned from undergrad is grit and how to be resilient and just keep pushing forward. And it just became sort of a mindset of like, okay, medical school's the gig. That's where I'm going. How do I get there? You just got to keep going through it.
Yeah.
So I graduated and knew that with my MCAT score and my MCAT score and GPA, those are like the two things that are going to get you into medical school. That's numbers. It doesn't matter how well-rounded you are, if you had a job, if you worked part-time, if you were, it doesn't matter. It's those two scores are the only thing that's really going to get your application on somebody's desk, unfortunately. Because I did all the right things. I worked in a research lab for 2 years, and actually that's how I think that was one of the best things I could have done. I worked in a lab that we studied cystic fibrosis sputum samples and bacteria that came out of these patients' lungs. And I was fortunate enough I transitioned into the lab right at the time when they were starting to do their poster presentations. And part of it was going to these conferences with families that had cystic fibrosis patients.
Wow.
And we would go there and present. And I got to meet patients and I got to meet families and talk about what I was learning. And I think me and another student, we got to basically build a presentation about our experience as scientists presenting to patients and what that meant. So there wasn't really too much hard science that I had to do in this research lab, but it was people science. I got to talk about what it meant to me as a student researcher, talking and interacting with the patients. And that pretty much solidified for me, like, I don't want to do anything with lab work. I don't like to be worried about syringes and sterile field. I want to talk to people and be with people all day. And so that, I think, gave me really great talking points for applying to medical school eventually. But I took a gap year, worked at a assisted living facility, which is great. I really love geriatrics and old people.
And see, that's kind of the thing. So you think about the medical education, and you've kind of pointed at it, and I think there are many who have gone through it, many who are in it now, that it is formulaic. It's kind of like, okay, this is just what I have to do.
Right.
But if you were to flip it, imagine if there was a course on, cystic fibrosis patients, and they brought in patients with cystic fibrosis, and the ones that whoever was the student in the audience who really didn't care or wasn't, then they'll read it out, because that's one of the biggest things is what we call bedside manner. That's not a course in pre-med. That's not a course in medical school, right? And in fact, I always say that it almost, I hate to say this, but coming from a science background, it kind of felt like pre-med was, basically channeling the wrong kind of person to be a physician in the humanistic sense. Now, in terms of the intellectual, being able to do hardcore, medicine. Yeah, but then separate them. I think, I do think there needs to be distinctions, and that, the path, it used to be back in the day that the training was generalized, but the reality is many people just go straight into specialty. So it's kind of like, okay, well then shouldn't that have started early on? I'm a family physician, so I think the path should be different. Because it really centers on that connection, that humanistic part, the whole community, the family, the patient. And it's missing, And so one of the things I'd like to do is juxtapose this to educational systems in other countries. So one of the things, and maybe if you even have some opportunity, you won't because you'll be going into more training, but there might be an opportunity to hop on when we're in another country or interviewing somebody else and just be part of that discussion. I went to Cuba in 2021 as part of an educational exchange through Howard University, my medical school. And I piggybacked off of a program at Howard that was going down there, and I found out they were going, so I dragged my medical student colleagues on that trip because I was fascinated by the Cuban healthcare system and their model of education. The model of education was, it was, for the first time in 2021, they had actually allowed 6 students from the U.S. to come and go to medical school in Cuba and study with a promise that they would return back to the United States and serve in impoverished areas. And that sense, that model was just fascinating to me. And we actually visited the medical school. It was a beachside resort back in the day before, before Castro.
That's nice. Nice change of view for sure.
And it was amazing just to see how they started the process of the future generation of physicians. And very much the socialized sense of medicine is that physicians were like seeds that they would, I would go to remote areas in Latin America and get on a goat and go up the hill, and I'd be sitting there and like, I'm the first doctor, and there'd be a Cuban doctor, sipping on Cuba coffee and being like, hey, what took you so long? And but when you talk about these stories, and that's very much what we're trying to share with viewers, is these stories to give some perspectives. And so where you are, I think we'll revisit that when we explore this more. So you could be kind of like, our poster child of, what your experience is now. So where are you? So what was medical school? Undergraduate was, the grit, right? What was medical school like?
Oh boy. So in between medical school, I got a master's degree at Johns Hopkins for a year. And that, I think, prepared me for the volume that I experienced in med school, because I don't think, had I had that experience, that I would have been as well prepared as I was. It was a lot. The first 2 years of medical school, I don't know, you'd have to pay me a pretty penny to go back and do it all again. It was a lot. I cried a lot the first year. It was very stressful.
I saw plenty, that just suffered through the first 2 years.
And I think that's part of my personality as well. Chad and I, we were long distance, and that was very stressful. It was probably the most stressed our relationship had been, just because, I was in class from 8 until 2 in the afternoon or so, and then you study all night long, and it's very much intrinsic motivation. So you have these looming things over you, like, well, you should be doing this, and you should be doing this, and you have this to do and think about, and it's incessant and it's never ending. And as soon as you finish one quiz, you've got an exam in 3 days, and after you finish that exam, you have patient encounters to prep for, and then you have to. It's just on the go constantly, and it wears you down. And
was it preparing you for it just to be a factory worker? You know, that's the thing. The pace is so fast and furious that you don't pause and appreciate. What I think are the foundational parts of why to be a physician in the first place.
Absolutely. Yeah.
So the first 2 years, the studying was brutal. And I certainly saw that. And then, so the model that you had was first 2 years, you did all your coursework, and then you transitioned to clinicals, right?
Sure. Yep. So we do everything for the first 2 years in the classroom. You take your boards, I guess you technically would call it your spring semester of second year. And then clinical rotations start that next fall. And so I'm just now beginning my 4th year of clinical rotations. So I got a lot of I found my footing. I feel like I'm a more established person in an exam room now. 3rd year, it's hard to be a medical student, especially as a 3rd year, because you're totally new to it. You haven't really had that much real life experience if you haven't been able to shadow, which is another issue as a pre-med student. Being able to get with a doctor to shadow is just hard enough as it is.
Yeah, that's true.
But then being thrown into the room as a third-year student, you're like, well, have fun, figure it out.
Yeah. Meanwhile, the patient's like, whoa, what
right.
the hell is this? A short white coat?
Is that a challenge whenever it comes to the shadowing opportunities, or is that something that is sort of, you are expected to do that, or it's a requirement that is not always fulfilled? How does that work out exactly?
It's like an unspoken expected requirement, but not really. Like, you expect every pre-medical student who applied to medical school to have shadowed at some point. Mm-hmm. So it doesn't make you stand out necessarily, but it would stand out if a student doesn't do it, I would say. But it's also like, hard.
Yeah, it's like an internship, just like if you're on, you want to do business and you do an internship with Deloitte or something like that.
Gotcha.
It's the exact same thing.
Same deal.
Yeah.
Okay.
Yeah, and it's hard. I mean, I found you're basically cold calling as like a 15, 16, 17-year-old, even 18-year-old, college student. Cold calling, cold emailing physicians like, hey, can I follow you around and be in your way with you for like a week? Would that be okay? It's just, and it's awkward. Like, you can't write notes. You can't really do anything. You don't know how to present a patient because you really have no skills. Like, all of that stuff you learn in medical school. So you're kind of non-functional and in the way. So it's just, I understand why physicians don't take, pre-med students, but so that's just an experience on its own. But as a third year, I'm taking histories and doing notes, and actually, I mean, I like to think I'm being productive. I'm sure my preceptors might say otherwise, but I try my best and be, part of the team. I think that's important, is I'm really learning how to work within a team. Because that's what medicine is, and that's what I love about medicine, is it's team-based. It's you're not an isolated, figure that's handling all of these things, because that'd be very stressful.
Yeah. I mean, to really care for patients, it must be across disciplines, between nursing, you know. And I'll tell you, my transition, I was at Howard, and at Howard, the transition, going, the first 2 years, the coursework, I could knock it out. I really struggled with, because I'm slow. I'm just naturally that way. I don't like to rush through things. And when things start rushing around me, I'm kind of like, whoa, wait a minute, slow down. And that doesn't jive well. So I just remember third year at Howard Hospital, walking up to the floor, and you can, just to paint a picture, it's like it's an institution, it's a hospital, the normal environment, but they had a core group of these Jamaican nurses that, boy, they saw you coming a mile away. They were hungry for you. They were like, this is going to be fun. And it was humbling, terrifying. I just remember sometimes waking up at like 3 o'clock in the morning, sweating, and like
cold sweats.
This is not going to go well. This is going to suck. And then the next day it's going to suck. And, it was just endless. And, the other part of it is when you are doing the clinicals, and you've probably experienced, is the on-call. I
actually don't have to be on call, thank goodness. But some students do. Absolutely. That's still a thing.
Yeah. Yeah. So that was the hard part for me, was OB on call. And that was my first experience. So, part of it is relating stories. When I was a third-year medical student, I was kind of just learning the ropes, just like everybody else. We're in our little white coats, and trying to pharmacopoeia and things like that. And it's obvious to everybody we were medical students. But I was a little bit older, so I could fake it a little bit. I was like, and fake it till you make it. But OB on call was where I hit the wall. So the on-call schedule, you can imagine that, being on call, the effect that it has on you physiologically, they even have studies where they equate like how many hours of insomnia or your lack of sleep you get, how inebriated you become, And
those are numbers they have?
Yeah, there are numbers. Yeah, like, post-call. And it used to be that call would be for, was unlimited. It was like 128 hours a week. Eventually, they cut that down, and now it cannot be more than 80. So you can imagine, what it was back when I was doing the training. It was brutal, and I suffered from depression. I mean, I hit the wall, and it was really the insomnia of being on call that drove me to that. I just collapsed, you know. I mean, it was just, and I was like, I've come all this way and this doesn't feel right, you know? So it was a lot of, but that was part of the grit, you know, pick yourself up, keep moving, you know, and that's part of the old punk rock, you know,
Right.
It sucks. And there's a lot of what I think a lot of people won't understand is the loneliness that can occur. It's crushing.
Absolutely.
And
Yes.
when you're dealt with serious topics, you know, it is, you know, there is, and you know, this is not unique just to physicians and medical students and residents, you know, nurses too, you know, it's crushing, you know. And so, you know, it's just one of those experiences. But so you're at a transition now from medical school. What do you see for yourself?
Well, I've decided on family medicine. For
Bravo.
residency. Yeah, I'm
Bravo.
excited. Yeah, it feels really good.
Yeah.
I feel really comfortable with that decision.
Excellent. I am so impressed. I just want to let's just pause and celebrate this, because I have lots of students who have come out from. I do adjunct at, you know, Georgetown, GW, and Howard, and I get students who come out and they want to do a rotation, and then I think it gets around that, oh, it's a cool rotation to go on. You know, you'll get some interesting stories, and you meet Dr. Brown. He's a character. And then I'd be like, so what do you want to do? Oh, orthopedics. And I was like, what? What the hell? Leave me now. And, you know, and then, or plastic surgery, and no offense, but, you know, it's just kind of, it was like, well, why are you coming to me? You know, I really want to be able to connect with like-minded, you know, future physicians, family physicians. And I chose family medicine because I wanted something that gave opportunity, that you can still, you know, if you want to do a sports medicine fellowship, you can do that in family medicine. You want to do an OB emphasis, you can do that. The sky's the limit. The only problem with that is the way systems are made in healthcare. It's daunting for family physicians, because we are not often the cash cows for the hospitals, and, you know, getting out as a young physician, it's hard. You can't just hang up a shingle. You know, there's, you know, hiring a whole army of staff. You know, it's, you know, I would question this for where you are in your town. How many physicians are fully independent? Out of all, what's the total number of physicians? And then of that, how many? That means that they don't work in a large group. They work for themselves. They don't have a boss. They have maybe a PA or an MP, and that's about it. So I'd be very interested to know. I'll tell you, in D.C., it's striking. In Washington, D.C., a major metropolitan area, you know, we have 12,000 physicians, you know, in the Maryland, D.C., Virginia area. And in D.C. itself, specifically, how many physicians do you think are fully independent?
It can't be very many.
So just throw a number out.
Less than 100.
Okay, all right.
Okay, warmish.
Now, do it. Keep going down. Less than
10.
Okay.
Keep going.
5, 3,
4.
4.
Hey.
Wow.
And I'm one of them. I mean, fully independent. That means there isn't, you know, they're not connected. And that independent, you know, unfortunately does mean that, you know, you can't do it with insurance.
Yep.
You cannot. And so you'll even find other physicians who are especially older who just, you know, have moved over into what they call concierge medicine. So I am considered a concierge physician by default, but I'm just a physician. I'm a family physician, and a house call physician.
Yeah.
So, but no, bravo to you, you know, because I'm sure other colleagues of yours, you know, maybe they're gung-ho, especially the orthopedic ones are all like, yeah, you know.
Yeah.
Giving you a hard time.
There are so many personalities in the students, especially. You could see, oh, that one's going to be a psychiatrist. That one's going to be an orthopedist. That one's plastics, derm, ophthalmology. Yes, all planned out. And yeah, you strike me as family. You also strike me as maybe general surgery. Because,
oh no.
Okay.
Oh no.
All right.
What's the vibe there? I have to know. Just not being in the field.
I've had some very pleasant experiences with general surgeons.
Okay.
You know, in the course of my training and then after. just because they're general, so there's when you start focusing into a specialty, it's like, you're just that, And as a family physician, one of your challenges certainly will be, you are the quarterback, you are the hub, but they don't pay for that.
Right.
I mean, if you really want to be to make a fundamental change for your patients, it means being a quarterback is handling where the ball's going. And in healthcare, there's a lot of punting. You'll have one physician say, well, that's not my specialty, punt up to the next one, and then punt.
Yeah.
And, it's bad. Yeah.
Well, one of the things that Leanne had mentioned in her form was that I think you had mentioned the original osteopathic school in the world there in Kirksville College. And now, is that related specifically to what your track is, or what was the decision to go there specifically? Or maybe it was kind of out of your hands. I don't know. But
so in the world of med schools, you have the DOs and the osteopaths, or the MDs, the allopaths. For instance, there is no difference necessarily. I got 200 extra hours of hands-on manipulation. It's probably crude to compare it to what chiropractors do. However, the founder of chiropractic schools and osteopathic schools were very closely ran in the same circles. So the ideas are similar. But for instance, I took the MD boards the first time around. So like the knowledge base is identical. Osteopathy was derived in the time of Civil War. Our founder, Andrew Taylor Still, he was a physician, but saw a need within his community that, for whatever reason, I don't remember the details. I'm a bad DO, but the need was not being fulfilled. And so he started more the idea of body function structure. Everything's connected. And so thus was born osteopathy up in tiny little Kirksville, Missouri. And so that's where DO has come from, is from Kirksville necessarily. So that's where it's all founded from. And it was kind of based in this need of local communities, smaller practices, local country doctors sort of idea. And so that's why you see, if you look at the stats, I think majority DO residents end up in primary care settings. That's just kind of where we are. That's not to say we can't specialize. It's just, I don't want to say bias, but it's hard as a DO to get into a super competitive specialty if you don't have competitive, if not better scores than MD applicants. It's just kind of how the game is.
That is true.
Rigged.
I have a patient now. He is 93, and his grandfather knew the founder for osteopathy. He was an osteopath. Yeah. So maybe in future, I'll share a photo and his story. I actually want to try and do some research. When he started telling me about this, I was like, really? And I started looking him up, and then I found a picture of him and I showed it to my patient, and he started crying.
Lo and behold.
I was like, I'm sorry to make you cry, but this is really cool. Because, the history is extremely important. Where are we coming from? Because what are people going to think about us 100 years from now? And then what do we need to do now to really make a future that's meaningful for ourselves? And insurance companies aren't going to do it for us. Pharmaceuticals aren't, right? We have to. And if we don't, and I think I think that's right. Osteopaths tend to have more of a community patient care oriented mindset. That's just the way it is. So
you hear the word thrown around, patient centered, like that's the gimmick, right? But with osteopathy, it's very much the patient is everything. So that's where the hands-on manipulation comes from, is that if you've got misalignment in any part of your spine, that could be the reason why XYZ is not getting better.
As you mentioned, spine. Exactly. No, it's true. Yeah. Being mindful of it.
Yeah, exactly. Mindfulness and very much connecting to the body and relying on the body as a self-healing machine. Like it has the ability to heal itself as long as everything's in line. And so that's kind of where we really rely on. And that's where primary care, I think, is the strongest. If we can start at the base, at the foundation, and make
Mhm.
sure that, everything's in alignment, whether that be, blood pressure, lipids, things like that. If you can
Mhm.
make all that great, we're not going to see long-term,
Yep.
issues. And I don't need to send you to go see the cardiologist because I got everything handled
Mhm.
here at home.
Right.
Yeah.
Yeah.
And it's a preventative approach.
Mhm.
You know,
Yep, absolutely.
it's digging in deeper than just what a laboratory value or an isolated blood pressure might show you. It's asking deeper questions.
Exactly.
And that's really the foundation of a good understanding of who it is you're trying to care for. I would say that in particular, when we start talking about a family physician, it is also the huge part, which isn't appreciated, is not just being the quarterback, but also the preventative medicine part.
Mm-hmm.
And I would encourage you. I don't know how much of an interest you may have, but integrative functional medicine as being a part of that. And we are getting further advances, and we've showcased this some on our podcast. But technology is always changing. And, they always, pharmaceuticals are interested in medications that they can make a profit on. So they want to treat a chronic condition that could be not prevent, maybe it may lead to, but you could keep it away for a long period of time, in some cases entirely. I was pre-diabetic. I had to go into my nutrition, my exercise, my stress, all of those things to kind of get myself back to a healthy state. I'm healthier now than when I was in medical school, for sure. Certainly during residency. But, the part of it is we have new things now that we didn't have 10 years ago. Like even if you look at diabetes management, we have tons of stuff. Which I wish my dad had opportunities for.
Yeah.
But then in functional medicine, we can take a deeper dive than we've ever been able to. And I think if we continue to promote that, then there will be more interest in, advancing those technologies. So genomics is one. Certainly, you can do a whole genome sequence on any patient. Right now, it costs about $1,000, but I imagine that's going to come down significantly. That information will, it is yours, but it is also being used to, machine learning is digging into it. And I think there's a general greater good for doing that. But then also the biochemistry, we did a little piece on labs that really take a deeper dive in terms of functional, nutritional, things that really do have a tremendous impact. And so, I think if, part of it is patients, I feel, need to be empowered. And you just having them come in, they sit in the waiting room, they draw some blood, you say, hey, your pressure's high, take this medication, you're missing out on so much, And I don't want to be part of that. I want to be part of something that, makes a fundamental change. Because I've seen the opportunities that exist, if at the right time, what that translates in dividends later, I have patients who I saw 15 years ago, and, they're like, hey, doc, I just had somebody recently, I hadn't seen him in 10 years. And I'm like, Dr. Brown. And I was going to the dentist of all things. So I was like, Dr. Brown. And it was heartfelt, it was just like, okay, that's pretty cool, And that's what I want to be doing. I feel like I'm in the right place at the right time. Yeah. I see for you, not that I'm a crystal ball, but, you are going to face some challenges, and there's going to be, but I think that grit that you have, that you had to get or acquire, I think, it's a shame that you had to go through that, but maybe that will sustain you and keep you resilient. Do you know where you want to practice?
Well, that's the question, right? So Chad and I, we have family in the area out here in St. Louis. I feel as though if I get a residency here, I will never leave. And that's not necessarily a bad thing. However, I feel like residency would be a really great opportunity to try something new for a little bit. You can do anything for 3 years. So both his friends and my friends are on opposite coasts. We don't really have, our friends here in the area. So we're thinking he'd love to be out in DC, actually, out that area again, or Chicago. And I would love to be in Colorado or Wyoming, maybe. So I don't really have a location. It's more of an environment that I'm looking for, because like you said, I don't really want to join a hospital group. I don't want to work within the parameters of a hospital system that tells me, I have to have a specific, I don't think I want to work within a hospital generally. I do want to do outpatient medicine. But I see more often than not, some of my mentors comment on the paperwork that goes in that's necessary to facilitate those sorts of environments. And it feels more, I constantly am talked about the paperwork. That's all I hear, is how burdensome it is and how drowning it makes them feel. And I don't want to hate my job in 15 years. I have a financial incentive to keep going and pay off all of these loans. But just like mentally, I am afraid of, the mental health repercussions of a system that, I believe, doesn't really care about its healthcare heroes at times. And often physicians and nurses are the sacrificial lambs for a machine that just is ready to capitalize on patients being sick and staying sick. So trying to find an environment that I can flourish as a provider and like empower patients to want to take control of their own health and feel good about it and that sort of thing. So I know that's kind of a broad picture, but that's what I'm trying to find.
Yeah. And the thing is that, you can't, part of it is finding where your sweet spot is, or your niche, right? There are people who need you out there. You can't be everything for everybody, unfortunately, because the system doesn't allow that. And I've had that struggle myself, so I get to choose, what I do. And choice is extremely important, because that's how there's value. And if you can't establish the value of something, then, it'll never be appreciated, right? So the way I put it is that it starts with a relationship. I had somebody yesterday, I got in a call 11 o'clock at night, broke out in hives and was just frantic. What caused it and everything. All right, calm down. Go to the store, get some Benadryl, take it, and while that's working, let's talk a little bit more. And then talking about it and learning a little bit more about her history and a variety of different things, we had a better sense of what may have caused it. So then she had to leave the next day, travel down to Hickory, North Carolina, where she says there isn't really great medicine. I was like, okay, well, I'm not out of this. So I'm going to dig in and I'm going to find you an allergist. So the next morning, 8 o'clock in the morning, I call a colleague down there, an allergist, and said, I need you to get her in today. And he saw her, sent the report. She'll get some testing done later, but her hives is, better. But that journey with her, we then had a conversation after that, a good 45-minute conversation that, I didn't really have the time for, but I was like, well, wait a minute, that's where the gold is actually. We broke through that first part, which is where somebody needed help, right?
Yep.
And in the process of going through them, they understood that I was there on that journey with them and that I was going to see it through. They could have gone into an urgent care. Okay, take some Benadryl. Give me your copay. Here's the insurance card. Goodbye. Good luck. Oh, still not getting better. Go back, see a different person. Well, Benadryl's not working. Well, why don't you try a short course of steroids? Goodbye. Good luck. And then that punting. So
repeats and repeats. Right.
Ad nauseum. And here's the thing: I can guarantee you, the processes are set up to train, either a PA or a nurse practitioner or a physician or anybody to lose their skills over time, thinking that they're doing the right thing. But, it's only when you really follow up with patients that you truly understand and have learned from an experience. You'll know, oh, I'm not going to do that again, or I'm going to follow this through because who knows what this is. There are so many different conditions, and I still get surprised sometimes. Something comes up. I just had a patient in the ICU, and it was just like, wasn't expecting that. But you would miss it, and that's what had happened. The patient actually gone to the hospital, they said, you're dehydrated, kicked him out. 3 months later, he ended up going into the ICU because it hadn't been addressed, and people were just punting, him around, and patient gave up.
Yeah.
So that's where the gold is. The stories, you'll have plenty of those. I would encourage, what I'm doing with John and others is really capture some of these stories, archive them, so that we can share them with the hope that it may have some impact over time, or shed some light, or lead to something. I won't be here, I don't know how soon I will be. I'm not saying like when I walk out the door, but I'm not going to be here. But, we're on this third rock from the sun for such a short period of time, let's have a good time with it, right?
Right.
It's short before you know it.
Yeah.
So the beard's getting longer, and but I say, and then that's a big part of it when I'm working with others, is also there has to be a sense of let's have some fun with it, because all serious gloom. It's very common in healthcare, especially. You'll see these programs where it's all like, oh, that's doom and gloom, like my 600-pound life, and it's like, okay, how many episodes of this do I need to see? Just one. And or is it Popper or something like that? I know that's entertaining. I actually like it too, but it's one of those things. I can tell you that when we try to go internationally, that I'm hoping that what that will do is open up the door for more opportunities to really explore this. And I'll be honest, my dad had an expression that sometimes you just have to let it burn. Our healthcare system, the way it is now, you could try, and I've done this locally and federally, to try to be involved in, decision-making policies and those sorts of things. The system is not going to change. And so you have to give up on it and do it yourself. I'm DC, and punk rock motto in DC is do it yourself.
Yeah.
There's no record label, so you make your own damn records.
Well, that was one of the points I wanted to ask about, because obviously generationally you're in different stages from your experience in medical school and exiting and then entering practice, and Leanne sort of on that cusp of getting into it. Did you think things would be different by this point in time whenever you were at that stage? And I'm sure there's some level of disappointment with being like, oh, it's actually all the same. Didn't change one damn bit.
Yeah, I tried, to work within the system. Maybe I'm, something's in the water in DC, or I'm just genetically just not capable of it. But I could let it fester in my mind and kind of discourage me. And, sometimes I do get in this funk.
Yeah.
But no, I just keep moving. That's the whole thing. You got to keep it moving.
Yeah. Yeah. Well, you going to be a house call doctor, Leanne?
Come out and do it. You're going to have a clinical rotation. You come out and do a house call in DC.
Yeah, that'd be great.
Well, it's chaos. I am uncontrolled chaos. That's what Paige says. It will be. It's whatever. It'll be. Whatever it happens to be in a day. I've got somebody just sent a picture of Halls, so I'll figure out what that is. Somebody else I just called in 2 medications. People who trying desperately to find Paxlovid, because it's not being rationed well. So yeah. So yeah. It would be think about it, if you get an opportunity. I know you'll have some rotations. I've had plenty of medical students. It's different now because I did work for a nonprofit, Unity Healthcare, that had a house call program, and we were serving in very low socioeconomic areas. But there I felt like I was working for a boss, and they were trying, like when I first started with them, they were like, well, you need to wear a suit and a tie when you go out into the neighborhood. And I got mugged in the first month, and I was like, yeah, I'm not wearing that suit and tie. I'm going to wear some dank scrubs.
Yeah.
And, it was like, so I ended up, I still do those charity calls every now and then. But we are kind of, you can't be everything for everybody, and you have to kind of hone in on,
Right.
the sweet spot. You have to feel a certain sense of accomplishment, and do people appreciate that,
Yeah.
And, some people do, some people don't.
Yep. Yeah.
Right.
Well, Leanne, I think that you had mentioned having just a few questions that you might want to pose to Dr. Brown, and maybe you've gotten a few of those out over the course of the conversation, but now's the opportunity.
Let's see. I've got a list here of the ones I've had written. Because I think you and I are kind of on the same page in terms of like the state of what this healthcare system is. I mean, obviously, since you're kind of operating outside of the norm. So how, as a young person, presumably, hopefully, I'll be able to work for a long time and be happy. So what would be your piece of advice for like a young doctor getting into this? Like how to protect my peace early on?
Don't get comfortable. I mean, when you do your training, that you'll be like, okay, I just need to get through this. And you should start planning now for how you envision yourself practicing when you get out. Every day that should be on your mirror, and it should be like, okay, this is what what are the things I'm going to need to pick up? You are going to need a certain sense of how to operate a business, and you have to decide, is that going to be a for-profit or a nonprofit? You have to understand that, a large number of these hospitals, Kaiser Permanente, others, organizations, they're nonprofit. So you need to know what it means to set up a nonprofit. I've operated as a for-profit for a period of time, not knowing that, where it would go. I've shifted now. Everything's going to go towards nonprofit because my intention is to hand it off. My intention is not to sell it. I've seen and I'm kind of sick and tired of seeing how healthcare is just a business for folks. And I really just want to be able to give this off to somebody who I think will carry it on. But a nonprofit is still a business. So you need to figure out, okay, how you do need to step outside of your comfort zone of how you are protected. And I think that's by design. They control you in that way. They don't want you to know how to do your own finances. They don't want you to know like how to do hiring, how to do CRMs and, get the word out and all that stuff, because that's a threat,
Yeah.
And
that's not industry specific. That's like, those are courses we never get a lot of help with from a very early age. And maybe that's all strategic. I don't know. So who knows?
Well, you need a workforce who's going to work. And, it's easy to do that. It's easy to manipulate, I think, aspiring young physicians. They find themselves in a situation, I have so much debt, I have to get, income. So if you want to get ahead of it, start, build a website, set up a nonprofit, say that you're going to do this, look at how others are doing it, maybe even in your own town or other places, and just take it every day, small little pieces. There are plenty of things to look at, lots of research you can do. Maybe you find somebody else like-minded who could be a potential partner, and you start talking about it, and you say, okay, what do you think about doing this? When you're in residency training, you're going to be there with other family physicians. It's like, okay, well, find the one that's like, hey, maybe we could work together. I was in a residency program, and I had somebody who I was like, oh, we could probably be partners. That was the biggest mistake I ever made. had a MBA, and so it was just like, oh yeah, really, okay. And I had been doing all the work, and after a while I was like, wait a minute, this is So you have to find the right people to work with, and then even then, having the right support people. That's one of one of my biggest challenges is finding people who, and maybe that's unique to DC, that it's hard to find good people who want to do good work, and it will be a struggle. Maybe that's different for where you are, but here in DC, it's impossible to find good people I can trust who will just take it and run. Whereas I have there's this issue of the law of diminishing return. You have somebody in who appears to be good for about a year, and then as that year goes on, all of a sudden you start to see, bloop, bloop, bloop. It's not, And then I would say that never have employees. Everybody's an independent contractor. That's a big no-no for me, even as a nonprofit. Because going into that model is also very much a struggle, And so it's you do have maybe a mentor, a business mentor, maybe who's not even in healthcare, to talk about those things and structure things. Okay. I think the more that you invest in that, even in your fourth year, if you have some time before you start your residency, and set up a 4-year plan while you're doing 3-year plan while you're doing your residency, so you could hit it right soon as you come out.
Okay.
I didn't do that in large part because I kind of already knew I was going to go and work for this nonprofit, but then they ran out of grant funding, and it was like, oh, we're closing down the house call program. Oh, isn't that convenient? Jerks, Yeah, I was like, thanks.
High and dry.
I went through all this training and thought, whatever. Yeah, so what it does teach you is that you can't rely on others. It is,
Right.
what you make of it, And that's what I've been doing for the last 15 years.
Yeah. I am curious, do you have any experience with direct primary care?
Yeah, direct primary care, I've certainly gone to a few of the meetings, initial discussions. So direct primary care is basically, it used to be, it's an offshoot of what was concierge medicine, which was a subscription service, which was heavily promoted really as a franchise model. And that the whole hub of concierge, MD, VIP, and others, it was basically a way for physicians to try to get back some autonomy. But it did create some discontent because you can't, as a physician, you can't be, I'm a concierge physician now, because you have to have systems in place. If you are going to do direct primary care, that means that you are not accepting insurance, so you are at risk. So it means that you have established a core understanding of what. I think it's better to work back for what you need financially, and from there map that out to what is it going to take, like the logistics part of it. There are organizations that specialize in direct primary care. They sell you basically a direct primary care practice. In Seattle, they had a large direct primary care movement. You'll see spotted areas of direct primary care. Even here in DC, there's a nurse practitioner who does it. I think it's worthwhile to explore it. I just don't like putting labels to it. I'm not a direct primary care physician.
Right.
I'm a physician, but there are some things to pick up on it, like how to set up your practice. I think that movement, the best thing that it did is it provided an opportunity to share resources and education about how to set up a practice. I do think that there are those who have kind of seen the opportunity and kind of taken it and run with it. So I'd be leery of joining a direct primary care practice, for sure. Try to set it up yourself. And anybody who tries to sell you a package of direct primary care. They basically have kind of stolen it from different practices and then marketed it and then spit it back out to you. And then, then it's up to you. Well, just do it yourself and you'll know better than anybody else. Yeah.
Okay. Yeah. I guess then I have a kind of a piggyback off of that. What are the red flags in terms of like contracts, joining a practice? Like what are things that a young doctor who doesn't have experience can get taken advantage for?
Well, the contracts is the biggest, the biggest contract is insurance, the credentialing process. When you are, you don't even know, maybe you do, maybe you don't, but you're already owned by Medicare. When you get out, if you want to see patients and charge them and they are Medicare patients, then you're already a Medicare physician. You can't charge them. You have to bill Medicare and get paid. Oh, I didn't sign up for that. Where did that happen? Well, actually, residency programs get money from the federal government, so therefore that's part of Medicare. So actually, you got roped in, you just didn't know it. Oh, God. So you have to opt out of Medicare and Medicaid. And you can't do that if you're signing a contract with a group that takes insurance. So you're in this weird position, okay?
Yeah.
I can't do this if I'm going to try and set up my own practice, You can't work in a capacity as a concierge physician and then still take Medicare if you're doing another job. I can't, if I wanted to work in urgent care, I can't. If there was a buddy of mine who had an urgent care clinic and was like, yeah, you should really come in. I was like, okay. And it was like, I was ready to start the first day. I was like, yeah, this will be fun. This will be cool. And he was like, yeah, I just need to make sure, everything, we got all the paper. Oh, and your Medicare number. And I was like, wait a minute, I'm opted out of Medicare. He was like, ooh. And he was pissed at me. I was like, why are you pissed at me? I didn't create this. I was just like, screw you.
Yeah.
I mean,
Inadvertently
you know who I am, right? That didn't dawn on you? So, yeah. I opted out Medicare very early on and, never looked back. I mean, I think if I wanted to do anything for a patient, it's my choice to do it. If I charge them or don't charge them. There are plenty of times I don't charge, and that's my choice. That means I've got skin in the game, and that means that they need to understand that too, that I exist. I'm kind of like the Lorax, I exist because of those who I serve. But if those people no longer exist, then I take my little butt, I go away, and I put unlessed stones around this really morbid looking carnage of the Dr. Seuss.
Right.
Yeah.
What have you found is the best way? Let me pause. The use of the word earnest it's funny. It's a coincidence because I don't know if it's any different from when you applied for residency, Dr. Brown, but we have to list noteworthy characteristics about ourselves. And the word earnest is something that I've tossed around like for the last 2 or 3 years, just in terms of thinking about myself. Yeah.
Imagine that.
Yeah.
Perfect fit.
And I find that defining it and giving a concrete one-off example is really hard to do, because I find that the best way to understand someone who is earnest is to experience it. And so I think that is one of my, as far as what my preceptors tell me, that's one of my strong suits, is my ability to talk to patients and connect with them very quickly and get them to open up to me and trust me. And so then my question to you is how do you find is the best way to connect with patients that might be skeptical or distrusting of healthcare professionals in general?
Yeah, I mean, when I started with Unity Healthcare, my first day I started calling patients. I was going to go out and do house calls. And when I was talking to them on the phone, I kind of changed my persona based on my environment. And so I was very casual with them. I'll see you at home and I'll be there in a little bit. And, I had certain nuances. And I get to the home and the first thing they're like, wait a minute, you're white. And I was like, yeah, I am. And so there was this apprehension, because they were kind of like, wait a minute. But it really was, as soon as they open the door, I tell them, thank you for inviting me into your home. I'm here to help. It's finding ways to connect to people that root to their faith systems, their, what is their own understanding of health, and doing it in a way that's, time is the worst enemy. Rushing through things is the quickest way to end a relationship of trust. So it is pausing. I very often, when I'm with a patient, I'll just be awkwardly quiet for a moment, because it resets things.
Yep.
Or if something's getting difficult, I slow down how I talk, and it just has this effect of making it so that the person is breathing again.
Right.
There's nuances, and you can see it if you just let go and experience it. It's about observation. It's about really taking everything in. And that's one of the biggest problems of working in a clinic. It's a controlled environment. You have no idea. You have no idea. So many times I've gone into a home and I'm like, I get it. I get it. I get exactly what's going on because I can see it. It's right here in front of me. It is also because you could be all in, but the patient's not all in. And you have to tell them, look, I'm all in. Are you? Sometimes you have to say that, I had a patient who was very resistant to everything I said. I was like, well, I'm in. You're not. So I'm out.
Yep.
And that's okay.
Yeah, being transparent.
There are, you are many parts, many hats you will wear. And the psychology of that, interaction is extremely, you have to understand there are personalities, there's history. You're walking into a situation, and it's, sometimes you have to walk away from it because it's toxic,
Right.
There can be, don't think, narcissism doesn't occur on the physician end and then the patient end too,
Sure.
There are, all kinds of experiences, and it's just weaving your way, and you'll find the pieces of gold along the way. There's no question about it. And then the ones who aren't, it's you just keep moving, I'm waiting for the next one,
Yeah.
where I think, where I will be able to have an impact, where I know there, when I'm all in, that it's a sense, not just financial, but, the experience of it, the story of it. That's the key thing I would say. I'm hungry for stories. And I'll say this, the reason I have seen the full breadth of life from birth to death many times over in my patients. For those patients in their last chapters, it is seeing them transition, where they were the mother or the father, or, some real powerhouse of a person in the transition, whether it's through dementia or, failure to thrive, that they are then locked in, and the only thing they have left are memories, stories. I want to bank those stories now, because that's what I'm going to feed on later. I can't say that enough. If nothing's worse than not having experienced things and fully, taking small bits and pieces is not enough. It's like, okay, that's a larger dividend. And that's maybe uniquely me. Maybe people are just like, I don't need that. I can sit by a beach, sip my Mai Tais. Like, okay, all right, that's cool. But I want to get stories.
Yeah.
Well, I think that's important too, but I was talking to, when I was with my psychiatrist, he pushed me to, on day one, he's like, what's your philosophy for practicing? What's your philosophy for healing? And he wanted me to type out what my phrase would be, or the theme that I would kind of run with. And I came up with, meeting patients where they are. And I think that plays to what you're talking about. And meeting a patient where they are is sure a standalone person, but behind them are these experiences, these stories, these histories that have influenced them to the moment that you get to meet them. And by ignoring those, I guess, you're discounting how they understand every single word that comes out of your mouth. And so I find myself a lot in the exam room frequently asking, does that make sense? Do you understand what this means? What do you know about this? How does this sound to you? How does this feel? Just so that I know that what I'm saying is being translated appropriately, because I never want to assume, because I know I'm in a very privileged position. I have access to the EMR. I know what it means forwards and backwards, but I know that not every patient that I'm going to come in contact with has any idea what any of that means. And I think that's what I really try to be cognizant of and make my highest priority with every single patient is, are we together? Do we know what we're doing?
Yeah.
We're on the same page. And I think that's, when I think of earnestness, that's what I think of, is being really sincere.
You have to do house calls. 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 You'll eat it up. Have you done them?
No, you think about it. It's like the quintessential country doctor making house calls with your little black bag. But I've never, in modern day medicine, it's really hard to picture
You'll never.
that.
Maybe I should not be doing this. Maybe I should not be doing this. But you do it one time and you'll be like, whoa.
Yeah.
That's what it was for me. I fell into this. Dr. Dibble at Howard was this legendary family physician. And he would see 60 patients a day in his clinic. He knew everything about the family, everything about every child, everything. He was just like this encyclopedia and the history of it. But then, he'd be like, I was just with another physician and in the hospital, which I really don't like hospitals. And so I was like, oh, I hate this. And then Dr. Taller, one of my mentors, went up when we were doing rounds, went into one of the patients' rooms, and Mary. And he was like, hi, Mary. You're doing much better, and I'll see you at home in a week from now. What do you mean? What? Wait, what? And yeah, that was it. You know, between Dr. Dibble and Dr. Taller, I was like, and it unfortunately, I mean, I was kind of like, wow, that's kind of cool. You know, I was kind of like, man, you know, but then I was like, driving back, I was like, whoa, wait a minute.
Yeah.
That's freaking amazing.
Yeah.
You know, something about it just kind of, you know, it just smacked me upside the head, and just everything from then I was just like, yeah, I can't ever work in a hospital or a clinic. And that was when I was, you know, 4th year of medical school. Mm-hmm. Yeah. So I should not be doing this to you. I feel bad about it in a way.
Well, Leanne, I mean, I know Chad still has plenty of his connections here, especially with his work with Senator Duckworth. So when you are inevitably both here at the same time in D.C., it's an opportunity to hop in with Dr. Brown and see what a day might be like. I think it'd be a really influential and transformative potentially experience for you to do that.
Yeah.
It'd be cool.
Well, I do know I've got, like, I think my schedule, I've been tasked with building it myself, but I've got, I think, like 2 weeks free in December. So
okay, all right.
Maybe we can work something out. That'd be cool.
Yeah, you know, we would film it, of course. But, you know, just to archive it, you know, and, you know, it's controlled chaos, I will say. I don't see myself when I'm doing these things, but, you know, I get comments, you know, like, you slow down, you know, or just, you know, I can be kind of fast with it, but yeah, I eat it up. I mean, you know, when I get up in the morning, I'm just like, okay, what's coming?
Yeah. It's very much, I think, a seize the day kind of thing. It's like whenever you have the opportunity to go out and publicly speak or something that's really going to challenge you to like get outside of yourself. I always, you have relayed this a number of times, but it's that kind of enthusiasm and that energy. It's like, let's go, let's do this. So I think there's that level of energy that accompanies going out into the field. It's one thing to be in a cubicle or box or whatever.
Oh my God, yeah.
And it's another thing to really go out and make your day as awesome as it can be. So
and not tethered to an EMR.
Yeah,
it's such a beautiful thing. Oh my God, yeah. I'm just.
I would say that sort of enthusiasm is hard to find in medicine. You don't, I mean, I'm driven by excited preceptors. They make my learning much easier when they're thrilled and motivated and want me to learn.
Right.
And it's hard to do that when you're with these guys who discourage you from going to medical school in the first place and are, you know, cranky about the whole thing and the paperwork and this and that. But it's nice to hear that you love your job.
Yeah, and you know, I mean, that's uniquely here in the U.S. You know, the other opportunities is to be able to do international work. You know, as a family physician, you have a broad spectrum, and that's where I think the opportunity is for you, where I think others have kind of locked in. And even some of my colleagues, you know, from medical school, you know, orthopedics and other things, it's kind of, they're locked in, and that's okay. You know, that suits them. Doesn't suit me.
Right.
So, you know, maybe you'll find something, you know, that will satisfy you when you're 80 years old, lying in bed and smiling, pleasantly demented.
It's a good, it's not the best thing in the world, but it's a good feeling to be, you know, like
that was a good show. You know, it was like, not bad.
Let's rerun it.
Yeah.
Well, Leanne, I just want to say thanks again for coming on with us. I know I've wanted to get you on here for some time now, and we finally were able to coordinate it. So I think you're in a really fascinating position now as you're in this transition phase and you start to enter the professional world of medicine. It'd be awesome to have another conversation to follow up on this, to see where things are. You know, obviously you're very motivated.
After first week of residency, yes. Let's put that in the calendar now.
Yeah, right?
Like, screw this! No, family medicine residency won't be like
Yeah,
that. You know, there are others that are, you know, like ridiculous. It's an old boys school.
Well, you do have an ER rotation, right, here coming up?
Yeah, and I think it's not next month, it's the month after that.
Yeah.
So
see how
depends
it goes.
on what the ER is like, you know, the culture, you know.
Right.
You know,
Yeah,
some
we'll
places
see.
it's bang on and others it's like, oh, good grief.
Yeah.
You know,
Yeah.
Needless. Yeah.
Yeah.
Excellent.
Sweet. Well,
thank you for having me.
absolutely.
Yeah.
We have an awesome amount of, you know, conversational pieces, and I wanted to, you know, hook this up so badly because I just see so much overlap for the two of you and your motivations for wanting to take care of people. I think you two are very much in line, and it's genuine. You know, I think that there's a facade for some individuals of wanting to do these sorts of things, but for the two of you, it's like the connection's there. So thanks for coming on with us, Leanne.
Yeah.
Sure. Anytime.
Excellent.
All right.
Fantastic.
We'll
Very
see you all
nice to
next
meet
time.
you.
Nice to meet you as well, Dr. Brown.
Yes, I wish you the best.
Thank you.
And if you happen to find any of this interesting, or more importantly, if you want to collaborate, check out the link below so that you can send us your comments, any stories you may have, anything. You know, we're happy to entertain it. And this is really about us going on a journey together.